So we're really honored to have Dr. Kathleen Kara Fitzpatrick here tonight. She is the Director of Outpatient Eating Disorder Clinical Services at Stanford Children's Health and is a Clinical Assistant Professor of Psychiatry and Behavioral Sciences. In real life, you can find her working on clinical treatments of eating disorders, researching treatment outcomes, working with patients and families in the outpatient setting, or teaching students. Her research interests focus on novel treatment development and neuroscience-informed approaches to care. She loves animals, kids, and feeding people. She's a terrific person and an awesome speaker, and we are really in for a treat tonight. Thanks a lot.
Just want to make sure, Sandy, is my volume on? Perfect. I'm loud. I actually really don't need a microphone. But what I wanted to do today is something a little bit different, and it's really something that my colleagues and I have been thinking about for a long period of time, and that is that for the most part, when we meet with families and when we meet people for the first time struggling with eating disorders, we feel like we often have to overcome certain myths over and over and over again. And these are ideas that we have about eating disorders and eating disorder treatment and what exactly that entails. And hence the Mythbusters Eating Disorder Edition. Uh-oh. How do I move forward, Pablo?
It should work.
It should work. Or not. I can do it off the top of my head. So, why are there so many myths about eating disorders? I think in part it's because eating disorder research, treatment, training has changed dramatically in the last 15 years. We've really gone from having an understanding of eating disorders as an individual disorder, as a psychiatric illness that people don't necessarily get better from. And we've really turned the corner with that toward completely different approaches that we might use. We've changed not just our knowledge base about genetics and environmental factors as well as age and developmental factors, but we've also changed our understanding of, excuse me, the ways in which these all come together. In order to change the landscape. And one of the biggest changes is actually in what the eating disorders are. So how many people here have heard of ARFID? Yeah, all right. So only about a third of you raised your hands. How many people here have heard of anorexia or anorexia nervosa? So you can see that there are some real differences in the kind of knowledge that people have. So when I'm talking about the eating disorders, what I'm really going to be talking about and focusing on tonight is anorexia nervosa, which is characterized by a failure to maintain a healthy weight, along with cognitive symptoms, which are incredibly important for this diagnosis, where people are tremendously afraid of gaining weight and where body image impacts the sense of self. What I mean by that is most of us try to look good, right? I pulled out a suit for you guys. That's got to be saying something. I even put on makeup, right? We try to dress ourselves in ways that we feel both comfortable with and feel reasonably attractive. But what we do is no matter how we feel about our bodies, if we're healthy, we still go out and do things with our bodies. No matter how I feel about, say, cellulite on my thighs, I still go swimming or I still, go to work every day. Body image unnaturally influencing your ability to get out and do things is part of anorexia nervosa. Bulimia nervosa is often thought of as a disorder where people purge or throw up, and actually synonymously think that purging and throwing up are the same thing when actually there are multiple different ways to purge. But the main difference actually between anorexia and bulimia is how much someone weighs, where people with anorexia nervosa are below weight or have fallen from a higher weight to a weight that's much lower than their expected weight, while individuals with bulimia nervosa are at or above a normal weight, actually, and engage in binging and purging behaviors. So binging gets a bad rap in our society, right? People talk about binging and binging on everything. My son and I are currently binge watching The Office. And even then, I'm not always really sure, when does it, how many episodes constitutes a binge? And how many is just, hey, they don't have commercials and they start automatically if you forget to do anything. I think that's how I get conned into watching as many as I do. In eating disorder terms, we actually are pretty specific. Binge eating and a binge can be objective or subjective. An objective binge eating episode is where an individual, and this is very important, loses control over their eating. They feel that they can't stop themselves or they're unable to shape their behavior around food and eating. And in an objective binge eating episode, eat what we would consider a gross, not gross as in disgusting, but gross as in large amount of food in a very short period of time. Often 3,000 to 5,000 calories in 15 to 20 minutes. That would generally be an accounting of a large binge. But you can also have subjective binges. And that's what most of us have when we're thinking about binging or when we talk about it in society, which is that same feeling of loss of control, but the amount that you eat might not actually be a large amount. In fact, it may be quite a small amount. It may be even considered an inadequate amount, but people can still feel that loss of control that happens. And when you have bulimia, you follow that with what we call maladaptive or inappropriate compensatory behaviors, which is just a fancy way of saying doing something that you really shouldn't do in order to get rid of that food or to relieve the anxiety around having eaten that food. Generally speaking, that is thought of to be self-induced vomiting, but can also be things like excessively exercising or burning off calories without ever engaging in any kind of dieting behavior. It can mean fasting, simply not eating. So you might binge and then fast for 24 hours and eat again. And if that sounds strangely like the kinds of things that you hear in the news that people actually suggest you do and have even made the rather gross and kind of scary assumption that doing so will actually lengthen your life, that would be just straight up wrong. But so things like fasts and cleanses can also be part of bulimia nervosa. And binge eating is the same thing, but without the inappropriate compensatory behaviors. ARFID, the new eating disorder diagnosis, is avoidant or restrictive food intake disorder, possibly the least glamorous name you will ever, I know it's not even descriptive. Like when I tell it to you, you're like, so what does that exactly mean? Can really be characterized as two things. Extreme picky eating, a lifetime habit of really having very narrow taste preferences and real difficulties in engaging around food. What's really interesting is kids with ARFID can look a lot like kids and adults with anorexia nervosa, but the difference is kids with ARFID don't have body image concerns. They're not driven by the same sense of their own physicality, and rather they're driven a little bit more by anxiety. They're worried sometimes about how a food is going to taste, what it's going to be like, whether they're going to like it. And so a subset of kids with ARFID will actually have eaten regularly, but had a choking, vomiting, or nausea experience that has then made them pull back from regular food and eating. And so there's this sort of lifelong extreme picky eating, and when we say extreme, we really do mean extreme, not sort of just the parents of toddlers who are annoyed that one day they eat a banana and the next day they don't. Kids with ARFID may give up eating bananas and never eat another banana again. These are also kids who may have choking or vomiting phobias, right? So it can be induced by things. And so they're pulling back from that. And then, of course, the largest category of eating disorders as we know them are the people who don't fit neatly in any of those boxes. And we've worked really hard to decrease that. But I'm really going to focus on the general eating disorders for today. So the things that I just talked about up here. And unfortunately, this doesn't look as good as it looks on my computer screen, but the kinds of things that people talk about associated with eating disorders are often caught up in ideas or cultural norms that actually aren't necessarily helpful when thinking about what to do or how to diagnose an eating disorder. So I talked about bulimia and binge eating. This is one of my favorite ways of thinking about ARFID. It says what I thought feeding kids was like and what it's really like. It's almost like the kids biting back. And this is the other thing that parents tend to be reminded of when they think about it, because kids with ARFID disproportionately prefer beige foods. They tend to be carboholics, and the kinds of foods that they often have a really hard time with are fruits and vegetables and things like that, which kind of makes sense if you're an extreme picky eater. Fruits and veggies don't taste the same way each time you have one, right? If anybody here's ever bought a bag of baby carrots, there's always that one baby carrot that's like white and kind of crusty and freaky. Or you get a container of blueberries and most of them are good, but one of them's always that like just super bitter, nasty blueberry. And then you're like, these things just don't taste the same. And that consistency is really important for our kids with ARFID. So truth or myth? You can look at someone and tell that they have an eating disorder. You should be able to know based on how they appear, whether they're skinny or they're heavy, not only if they have one, but what type they have one. What do you guys think? I'm hearing a lot of nah. No, not at all. In fact, a majority of people who fall into the category of having an eating disorder have a healthy or above healthy body weight. It is only in extreme cases and fairly infrequent cases, such as anorexia nervosa, when we have not caught it until someone reaches an extreme weight, that people actually look very, very thin. People can actually be a healthy weight and be catastrophically ill. And so what you can't tell by looking at someone. And even if someone has gained weight from a low weight to a healthier weight range, does not mean that they are not still ill. In fact, oftentimes, especially with anorexia nervosa, as people gain weight, they become more psychologically distressed. But it makes sense in that context, right? We've removed the strategy that's been helping maintain their mood and emotion regulation, restrictive eating, and replaced it with behaviors that are difficult for them without having the time to build up some of those coping skills and strategies. And so you can't tell by looking at someone, and weight is a very poor predictor of how ill or who is ill. This is one that is definitely pervasive in our society. And I think it's probably pervasive as either a truth or a myth because we are very much an individualistic society. And so I put these two together because they really do go together. Are families dangerous? Do they cause eating disorders? Can they be problematic? Maybe. But in our understanding of whether or not families cause eating disorders and whether treatment should be individually focused, the answer to both of those, is no. Why? What we found. In the previous research, decades of research, the authors would publish things saying that families of individuals with eating disorders are overly enmeshed. They're too connected to each other. Right? There's no independence. These were also called psychosomatic families, meaning that they were families who communicated well around medical challenges. And that over-controlling mothers, because it's always the mothers, right? It's like the dads get off really easily, but over-controlling mothers would result in eating disorder behaviors. In all of the research that's been done in about the last 30 years on that, we can say definitively that that is not true. Now, can families be challenging? Absolutely. I have one of my own, both the one I came from and the one I'm building. Families are challenging, right? You may, as a parent, or you may have been parented in a way that made certain challenges more difficult. You may have been given ideas about food and eating and body image, shape, and weight that aren't useful to you and may actually be dangerous, but that doesn't actually mean that families cause eating disorders. We now know that there's a very resounding genetic and environmental influence that are critically important for the development of eating disorder behaviors. And it's not genetics alone, and it's not environment alone, and it's actually probably not even a choice in terms of how things start, but rather a constellation of these factors. In addition, we know from working with children and adolescents at least, that in children and adolescents, family therapy and family-based treatment is actually the best way to help bring people back to health. So while families may have their difficulties, and certainly we all do, working with those in a treatment context can actually be tremendously beneficial. Specifically because if somebody's giving you messages that hold your eating disorder in place or that make it harder to reach recovery, don't we want to help them have the skills in order to begin to overturn that? And we know that family values around food and eating are actually deeply entrenched. Did you guys know that food is the first independent skill we give kids? Before they can walk, before they can talk, before they can even hold their heads up straight. We're allowing them, well, not really allowing them, they choose how much they're going to eat and when they're done. And anybody who's ever nursed a baby has had to live with the anxiety of having absolutely no idea how much this kid has had to eat and having to trust that that's going okay, or to get help if they don't. Toddlers may choose their food even though they can't. You would never trust them to drive a car. You would never trust them to actually really make any reasonable or logical decisions. If anybody's hung out with any toddlers recently, that should be deeply confirmed in your brain. And yet, we ask them what they'd like to eat, and then we serve it to them as though that's a normal type of interaction. And so we know that families have really strong value systems around food and eating, and intervening in those and helping families move away from illness and toward things that maintain health is actually critically important. Once an eating disorder is in place, families have much knowledge to bring about what helped people stay well or get well, or what wellness would look like for them, but the way in which you need to actually eat in order to overcome an eating disorder may be something that has to be learned in that family. So for example, anyone know what one of the best strategies is for overcoming bulimia and binge eating in relationship to food? Told you I wasn't gonna pick specifically on anybody, but anybody know? What's that? That's a treatment, the Maudsley method, but actually simply normalizing your food intake, eating regular meals. In about 30% of cases, just simply implementing regular meals and snacks can help reduce symptoms significantly. Not necessarily getting a cure, but 3 meals and 2 snacks for children and adolescents, sometimes 3 meals and 3 snacks if you're more active, is actually vitally important for overcoming eating disorder behaviors. Kind of seems a little bit counterintuitive that it should be so easy to just eat, right? But it's not so easy for those of us who work with eating disorder patients. That's actually one of the hardest things to do. Eating disorders are health crises that disrupt personal and familial functioning. True or false, guys? You're like, that's why we came here. True, you knew it was going to be true. I haven't put up a true yet. Or you thought they were all going to be false. Just messing with you a little bit. I think one of the things that I know my colleagues and I would love for people to walk away with is this information. Eating disorders are the most deadly mental illness that you can have. Anorexia in particular kills more people than depression and schizophrenia combined when it is left to be a long-term disorder. It can become a chronic disorder, as they all can. And so not only is intervention important, recovery is critical. What kinds of things can you struggle with as a result of an eating disorder? Well, your body requires food and nutrition. And whether you're getting too much of it or too little of it, or you're getting rid of it before your body can use it, it affects absolutely every single cell in your body. Things that we know. Individuals presenting with eating disorders, and this is true for both anorexia and bulimia, can actually slow their heart rates. They can actually become what we call bradycardic, up to and including needs for hospitalization. And for both anorexia and bulimia, increased risk of cardiac maladaptive cardiac events or significant cardiac events are one of the major outcomes that we are trying to reverse. And this can happen from different pathways, right? When people are purging up or vomiting up their food, they're actually purging up their potassium stores. You store potassium in your stomach. And when you purge that up, potassium, if you guys can really like kind of go back to like 10th grade bio class right now, right? Everybody wants to go back to 10th grade bio class, I'm sure, especially on a Thursday night. You might remember potassium is one of the things that actually makes your muscles twitch. It's vital in cellular communication. And so these eating disorders can actually catastrophically impact the body. We also know that it affects brain processing, not just what you are thinking, cognitive content, but actually cognitive process, how your brain actually develops, those changes that occur during adolescence, and the aspects of cognitive development that get set into place. And so we know that these disorders can be incredibly disruptive. Bone health and reproductive health are also at critical risk in the face of all of the eating disorders. And you might be saying, well, wait a minute, how does that affect binge eating? How does binge eating affect these risk factors? As much as I love food and feeding people, eating too much in just one short period of time actually puts tremendous stress on the body. And we know that with excessive binge eating, we can end up with things like high cholesterol. We can end up with aspects of heart disease. We can end up with risks for catastrophic and fast weight gain. And that's particularly problematic for women and their hormonal systems, where our fat cells are what produce estrogen. And when estrogen is produced in too much or too high of quantities, we can get physical side effects. Binge eating increases your risk for metabolic syndrome, which is a combination of typically elevated blood sugar levels or prediabetes, as well as high blood pressure and high cholesterol or dyslipidemia, changes, so low good cholesterol and high bad cholesterol. And so we know that it's not just the absence of food or dysregulation of food, it can also be too much of a good thing. And when we recognize that, we have to also recognize that because you can't tell who's ill, I can't look at someone and know this person needs to be in the hospital. In fact, after more than a decade of doing my job, I am so bad at that I'm actually worse than chance. You would be better off flipping a coin to determine who should go into the hospital than to ask me. And that's why we work so closely with the medical team here, is because a true understanding of the physiological as well as psychological and developmental impacts of eating disorders is critical for helping overcome them. I think you guys already kind of know this because I sort of got a little bit ahead of myself and I got all excited about the fact that eating disorders, well, maybe, are not choices, but are actually biological illnesses with genetic as well as individual factors. Come on, guys. Y'all know the answer. True. But what do I mean when I say that? We know that you can inherit a genetic risk for developing anorexia and bulimia. With bulimia, it's even less clear than it is in anorexia, but having a family member with an eating disorder does put you at greater risk, but it does not confer direct risk. In other words, you need something to pull that trigger on your genetic risk. And the genetic risk is not one single gene, it's multiple genes. So what are we really looking at? Well, we know that kids who develop anorexia tend to be a little bit more perfectionistic. They tend to be more conscientious. In other words, they like to do things right. They like to do things well. And I gotta tell you, as a parent, right, that's fantastic. Who doesn't want a kid who wants to do things well or who's driven? But these same sort of rule-based behaviors can sometimes become more catastrophic when they become related to things like how to eat, right? We also know that your genetic risk can have the trigger pulled by activities that we almost all engage in, namely dieting. And if we look at studies that look at adolescent behavior around food and eating, how many, or I'm trying to figure out how to do this so you guys don't feel picked on. How many of you in your lifetime as adolescents skipped meals? Some of you guys are like, nope, nope. I hear all the time from the kids that I see with anorexia, bulimia, and binge eating. I don't have time for breakfast. I skip breakfast. I don't need breakfast. I'm not hungry for breakfast. if you have a healthy, well-developing kid, you still want them having breakfast. But if you have a kid with an eating disorder, any meal skipping is catastrophic, right? And that actually increases the risk that those genes are going to come into play, because your genes are not like what you're born with. They're actually flipped on and off by different behaviors and things that you engage in. The metaphor that was given to me that I really love is you have to imagine your genetic code like a room filled with pianos. And depending on what's happening, different keys on those pianos are being played. So in people who are at risk for eating disorder, even something as simple as skipping meals or falling below that caloric threshold where your energy intake is lower than your energy expenditure, so you're burning more than you're taking in, can be enough to begin to flip on aspects of that genetic code that put you at even greater risk for an eating disorder. And that's true even amongst people who never intend to develop an eating disorder. We see so many adolescents who start off and they think they're doing all of the right things, right? They want to eat clean. Have you guys heard this? Clean eating. To me, your food is clean if it's been washed, right? I'm hoping you're not eating like carrots that you just pulled out of the ground. Well, and even then, I probably prefer that to some other things that you might be doing, like juice cleanses and fasts. We have a lot of information, maybe too much information, about healthy eating. Right? You can't go online without hearing that sugar is bad for you, but carbs are also bad for you, but saturated fat is terrible for you. What's left? You can pretty much eat kale and blueberries these days and feel like you're doing it right. These messages are typically aimed at overweight, sedentary, middle-aged people. In other words, they're aimed at me. They're not aimed at adolescents who have far greater biological needs. And when I say adolescents, I should be clear, I'm talking really up until about age 25, right? So the good news, the takeaway message is that some of you might still be in your adolescence, and if you're not, you're closer to it than you thought you were. But the fact is because the body is still growing and changing and developing, until that period of time, until about age 25 or 26, the biological need for food and energy is far greater than it is when you're my age. I'm decomposing on the spot. I have hit my prime, and it is all downhill from here. And so when you hear things about, like, I went on a 500-calorie diet, we know that that's actually dreadfully insufficient for children and adolescents. How dreadfully insufficient? Most need around 2,500 to 3,000 calories per day. 1,600 calories a day brings kids into organ failure and starvation over time. That's the number that we can starve people with over time. So if you are encouraging your kids to eat, or know of kids who are eating less than that and tracking their calorie content, we know that the ultimate outcome of that is going to be very dangerous, changes in heart rate and blood pressure. The same thing happens if people are engaging in purging or excessive eating. Worries that we might have there would be things like 10 to 20 pounds of weight gain without a linear height acceleration. In other words, you're not getting taller, you're just gaining weight. That type of rapid weight gain can actually be a signal that the body is not only not processing food in the same way, but may actually be having an inflammatory response. We see that in weight clinic very often. Because I work all ends of the spectrum, what I often see in my morbidly obese patients and kids and families that I work with is they're eating the same amounts that my kids with anorexia are eating. This group's gaining weight and this group is catastrophically losing weight. What you put in your body is not as important as making sure that your body is getting what it needs. And as much as I think it needs kale and blueberries, it needs a lot of other things as well. Eating disorders are about having or wanting control. Without a doubt, this is the thing that I hear the most often from families, members, from kids themselves. So who wants to take a stab? Is this one true or is this one false? It's hard to say, right? So let me ask you guys, how many of you guys like having control over your life? Yeah? How many of you like picking your own clothes to wear? Choosing when you shower or go to bed? Yeah, I'm still getting nods, and you're not nodding, I'm a little worried. How many of you guys like being able to kind of decide what you're going to eat or where you're going to go? Control freaks. You're all control freaks. As people, we exist and we thrive with consistency and structure. And I really want to be quite clear that that's different from this sense of over-control. The idea that eating disorders are about control is actually false. This one's hard for a lot of people because even people who are struggling with an eating disorder may say, well, I want to control my body. I want my body to look a certain way. I want to feel a certain way. I'm not confident or I don't feel good in this space. And when I don't eat, or I eat too much, or I purge after a meal, I feel better. So I've got to ask you guys, how many people walk through your day trying to make your life better? Yeah? People deliberately move out of your way while you're driving on the freeway so you have a straight shot to wherever you're going, right? People make sure you're happy before they deliver news to you. Or if they give you bad news, they do something really awesome to make up for it, right? No? So we've already decided that you guys are control freaks. And now we're adding to it that other people don't go out of their way to let you get your way. These two things really combine into an important thing about eating disorders. The development of an eating disorder is often about wanting change. It's about wanting to feel different. And I'm using feel instead of look differently because it's really hard to change your physical appearance too much. Like your nose is your nose is your nose, and short of plastic surgery, your nose and a broken nose, your nose is your nose is your nose. Well, your body is your body, and you can change your weight to a certain degree, but you can't actually usually change your body habitus, and your body is driven to maintain that. My body likes this weight. Now that it is this weight, it would like to stay this weight, and it will do almost anything in its power to do that. And that's actually outside of my psychological control. When we talk about eating disorders being about control, what we're often really saying is these disordered eating symptoms feel good to the person who is engaging in them. And that has to be one of the most challenging aspects of an eating disorder. Eating disorders, by and large, are what we call egosyntonic. They feel good to have. That's especially true of anorexia, but it's also true of the behaviors that we see in binge eating and bulimia nervosa. In other words, what I might think about as the problem, eating too much, starving yourself, purging behaviors, compulsive or excessive exercise, people who are struggling with an eating disorder look at as the cure to what they are often struggling with, which are feelings of incredible body dissatisfaction, maybe feeling like they could be more confident, they could have better self-esteem. And is any of this resonating with you guys? How many of you in here want to feel more confident? How many of you guys want to have better self-esteem, feel better about yourselves? So now you're all control freaks, and you have people who go out of the way to make you feel better, and you all have an eating disorder? I don't think so. What we have to move away from is this idea that eating disorders are choice behaviors. If anybody has ever had an eating disorder or lived with someone with an eating disorder or has worked with people who have eating disorders, the one thing that should be abundantly clear to you is that no one on earth would choose to have an eating disorder. It is disruptive in every way possible and rarely, if ever, leads to the very behaviors that people think it's going to. In some ways, it's that definition of insanity of doing the same thing again and again and expecting a different outcome. And so it's really important that we recognize that what we often think about as control is actually a symptom. It's actually what this drives the disorders rather than what will solve the disorders. The other thing that's really important to remember about eating disorders is that we don't know an actual cause. We actually have very little, if any, idea what starts an eating disorder for any individual. There are certain risk factors, right? Energy imbalance, or dieting, engaging in behaviors like vomiting after meals or exercising more than you're taking in, maybe using laxatives or things like that to help you with weight loss, restricting your intake in any way so that you might later binge or overcompensate. Those are all behaviors. And actually, if we look at the base rate of those behaviors, more of us in this society engage in those behaviors than not. Did you know that some studies suggest that as many as 60% of women on college campuses are engaging in purging behaviors, self-induced vomiting in particular? So these behaviors are not that unusual. Sad, terrifying, right? Several of you are looking at me kind of going, I had no idea. Dieting, any idea how many women in America diet? What was that? About 90%. Really, really close. About 87% of American women say that they have dieted in the last year to year and a half. Sadly, 67% of middle school students say the same thing. So these are behaviors that we're practicing over time. It's not about having control, it's about practicing habits, right? These very habits that are starting and then become something bigger. And so while we don't know what causes eating disorders, we know how to disrupt the symptoms of them in order to help bring people back to health. Uh-oh, I did that in a bad way. Eating disorders affect people of all ages, gender orientations, sexual orientations, weights, socioeconomic status. In other words, and since it's already up here, eating disorders look like everybody in our nation. Do eating disorders affect boys? Yeah, actually a lot more than we thought now that we're better at identifying boys. So we used to think it was about 0.5% of boys suffered from eating disorders. You know what really they suffer from? Not being diagnosed with eating disorders because they are boys. People used to say, well, mostly eating disorders affect rich white girls, right? I don't know about you, but all the public service announcements that I saw in high school all featured like really cute, tiny blonde girls getting anorexia nervosa. That's not what it looks like. In fact, eating disorders, and all of them except for ARFID where we don't have good data, are increasing the most in our Hispanic female population. But you know who else is at huge risk? Hispanic males for all of the eating disorders. We see these across nationalities, ethnicities. But what's really interesting is that eating disorders tend to develop during adolescence. That's one of the reasons why I'm such a fan of developmentally based treatments and the importance of development, is that we know that the peak age of onset for most of these disorders is between 12 and 24 years of age. You want me to be a little bit more specific? For anorexia nervosa, there are 2 peak ages for boys, actually. 13, 14, and 18. And those boys actually can look very different from one another. So 13-year-old boys often come in having that exercise physiological imbalance, and almost to a one, they all say the same thing. I really want 6-pack abs. These are boys who are trying to decrease their intake to give themselves a physical look because, right, if anything's changed in the last few years, it's not that we've gotten easier with how women should look. It's that we've gotten much, much, much harder on boys. I really feel for them because all these years where we're like, you guys have unrealistic body images for us. Well, we've just turned around and done the same thing to them, and it's not good for either of us. 18-year-old boys tend to experience this sort of at that nascent age of going off to college and learning how to do things for themselves, right? And they often start to get feedback or want to change how they're eating. For girls, that peak age of onset is 14 for anorexia. For bulimia, it's a little bit older. It's closer to 18 for both groups. You kind of noticing something? What happens at 18? College for some of us, for a lot more of us now than ever before. We're supposed to be adults. I have to use that in air quotes because like that whole notion of like being independent and not relying on your family, like I am seriously middle-aged and I still rely on my mom, my poor mom. But I think most of us do, right? And especially in this community. And so what we see is that actually this rate of eating disorders increases for people going off to college, because often it's the first time that you've had widely available foods, right? Think about a cafeteria at college. How do you make those choices? How do you engage with that? How do you know what to have? How do you know, I don't know about you guys, but I always slept through breakfast at my at university because the cafeteria was only open from 7 to 9. It was like, pfft. So I skipped breakfast for like the whole time I lived in the dorm. And that meant that lunch and dinner had to also be breakfast. And then I was also scavenging snacks for later in case I got hungry or stayed up late. So that dysregulated eating can sometimes be part and parcel of actual healthy development. We know that these disorders exist across different types of sexual orientation, with our LGBTQ kids being at greatest risk. And we especially see this in our trans population, where the desire to manipulate or to prevent that ongoing sexual maturation is huge amongst a small subset of our kids. Now let's flip this around to kids who might be overweight, right? Who are desperately trying to fit the norm of losing weight. Because if there's one thing that has made me sure that I will never lose a job working with eating disordered patients, it's the war on obesity. The war on obesity has actually probably created as many people with eating disorders as almost anything else we could possibly do. When we give you the message that your body is not only not okay, but a ticking time bomb, and if you don't do something about it, you're going to die, sometimes the strategies that children and adolescents adopt are those very strategies that are actually going to put them at risk for death. We know everyone knows someone with an eating disorder. This one's possibly one of the saddest aspects to me. I don't know that I have worked with very many families who don't believe this, that this idea exists that if you have an eating disorder, especially anorexia nervosa, you will never recover. I have to tell you, that's a big pill to swallow when you're telling somebody, I'm worried about your eating. I'm worried you might have this disorder. People and parents will often say to me, or young adults will say to me, so I'm going to have this for the rest of my life? What do you think my answer is? I hope, given that I was smiling at you guys, that you know that this isn't true. I don't know that I'd be able to do my job if I didn't believe that we could get people well. And fortunately, I'm also a scientist, so this makes it really awesome, because that means I get to study it. And guess what we find when we really study it? Two things are really true. No matter what, we can definitely decrease the impact of eating disorder symptoms on people's lives. We can improve family functioning, and we can reach full cure. And that's especially true the younger you are when you get treatment, but that makes sense because your brain is more plastic and it's moving, and we can create different structures. But we now know, even in adulthood, people can reach full cure. The longer you are ill, the harder that is. But actually, you can fully recover from all of the eating disorders. And in fact, full recovery is where we end treatment. So don't take this idea that you have to suffer or struggle, or take it with a grain of salt, I guess, because we know that not only can we get people to a healthy weight or healthy weight range, a little less so when we come from a higher weight, our overall BMI may still remain high because that's where our set point is, but we can improve the functioning on both ends of that system, from low weight to high weight, and we can also help with the thinking. And that's really critical, right? It's not that you walk around and you're eating healthy or have a semblance of that, but you internally struggle against it every day. That's not health for us. So we know we can get normal thoughts and cognitions. And let me just say one thing about that really quickly. How many people in here think their body is a wonderland? Right? Yeah. It's awesome. You can go into any store and buy things. You never get a little anxious about going bathing suit shopping, right? Everyone in here. When I say recovered and I say cure, I really mean in the context of how most of us are about these things. About the only time where it's really acceptable societally, not just like acceptable. I would love it if people walked around loving their bodies. But about the last age where you can do that without having a serious clapback is about 4. right? When you're 4, you can be like, I'm awesome. And when you're 5, people go, don't brag. We give each other messages about what is and isn't healthy, and that actually can help. That actually influences. Body image dissatisfaction, this is really sad, is the norm, not the exception. So one of the things that we're often looking at is how do we avoid the limitations that body image dissatisfaction puts on us? How do we work around that? How do we feel the best in what we have with what we're given and in the way that we want to be? And said very specifically, my goal is always to reduce the distress, agitation, and anxiety that comes with existing in a physical space that realistically, y'all, you don't have that much control over, right? I don't know about you guys, but my body does all sorts of things on its very own without me thinking about it. And I'm super happy about that because I'm not standing up here trying to remind myself to breathe, right? My body's just doing that. And when I get hungry, I don't know about you guys, but I get to that point where I'm hungry and nothing else is going to help me other than eating. And that's a good thing. You actually want that. The absence of that is a bad thing. Eating disorders are just about being thin and they're just about body image. And it's hard to understand this because I've been talking an awful lot about body image and distress and things like that, but I think we just put it out there. Most of us are somewhat distressed by our bodies. So are eating disorders about that? Is that what causes them? It's kind of hard. A lot of you are saying no, and you would be right about that. Anorexia nervosa has actually been codified in the medical literature for hundreds of years. And if we actually look back, we can find historical case reports of anorexia nervosa, especially binging and purging, throughout human history. Even when what was an ideal body form was more like what I've got, right? I'm definitely like a 16th century kind of chick. Like I would have been awesome, right? I can sing soprano, right? I can pack on weight. I've got like babies made for hip-making baby hips, right? The fact is that yes, our body images, ideal body images have decreased over time. In fact, in the US right now, what we consider attractive for females is anorexic. If you look at the numbers that they give, and that they even give these numbers should say something, on America's Next Top Model or Playboy models, most of those people actually belong in the hospital for acute malnourishment. They fall below the 75th percentile for median body weight for their height. Also, people lie, but that's okay. And so what we think of as attractive is emaciated. And it's really important to remember that. Now, it's not just about being thin, and it's not about being controlled. So what are eating disorders about? The best way I can describe it to you is this. Eating disorders are a set of habits or behaviors around food and eating where we overblow the expectation of how important food, body image, shape, and weight are. And we change our behaviors in ways that actually become replicating cycles. You know what's really hard is purging after you've eaten a large meal actually releases a lot of the same neurohormones and chemicals as having an orgasm. And we've done studies in rats. We'll never do these studies in humans because when I tell you what happens with rats, you'll go, yeah. When we hook up electrodes to a rat brain that allows them to have an orgasm over and over and over again by pushing a button, do you know what they do? Male rats. We studied this in male rats. That ought to shorten the path to the answer. They actually push that button so much that they stop eating, they stop drinking, and they would push that button until they died. If you could engage in purging behavior and recognize that it completely changes your emotional experience, if you could hit that reset button on your mood, how many of you would be able to keep your finger away from that button? Had a bad day, somebody pissed you off, you hit that button and you feel totally differently. Restricting your eating or dieting, if you do it long enough, actually decreases or changes your mood state. It actually shrinks your affective range. So your mood becomes a little bit, well, not a little bit, quite a bit flatter. Those of you who've been around folks with anorexia nervosa will find that they generally operate in a very kind of flat sort of way, and their blinking is slowed down and their affective range is slowed down. And also the humor muscle wastes away really quickly. And so what you see is that actually rigid dieting over a long period of time can actually serve to regulate emotions. So can purging, and so can binge eating. So what we're actually doing is hitting on reward circuitry in the brain and the body in ways that actually make it more likely that you're going to engage in these maladaptive, inappropriate, super dangerous, but also really satisfying behaviors. So we know that. I love this one. Not thin enough, you're disgusting and almost perfect. One of the things that happens when people get on the trip of trying to change their bodies, and let's be real here, most of us in this room have done that, it's kind of never good enough. Have you guys noticed that? Doesn't matter how you thought you'd look. Once you learn how to do that makeup trick that actually gives you cheekbones, I'm still struggling with that one. Or, you know, you get your hair to look really good. You can feel kind of good about yourself, right? Who here does not like a good hair day? They're really great, right? And they're also something that then you want all the time. And when you don't have it, what happens? Do you feel okay or do you actually feel worse? Worse. For most of us, if we feel like we're achieving something and then that levels out, we actually become distressed by where that has leveled out. We can become distressed with our new norm, even if our new norm is better than what we had before. So you've heard me talk about some of these challenges and some of these myths. What I really want to also talk about are what are the truths of eating disorder. The fact is that we don't know or we can't say who's going to be at risk for an eating disorder before they develop one. The other thing we can say is that one of the truths is that we are so bad at catching them early that when we ran a study trying to figure out whether or not we could help families, it was called Parents Act Now, and it was for family members who were concerned that their adolescent daughters were developing eating disorders. 100% of the people who contacted us about that study, their child already had a diagnosable eating disorder. We don't know the signs until they are too late. And so what are these truths? Anyone can have an eating disorder. Eating disorders can start at a very young age, particularly ARFID. We can generally pretty reliably diagnose ARFID by age 5. Extreme picky eating, these are kids who instead of adding food are getting rid of foods. So just in case you don't know this or you're interested, language explosion and dietary explosion should happen about the same time. So between a year and 2 years where kids are adding tons of words to their vocabulary and really learning how to speak and engage, they should be adding tons of food to their diet. We know that kids who don't get that from the very beginning are at increased risk over time. We also know that eating disorders and healthy behaviors overlap quite a bit. I would be crazy as a health professional to say to you, I think that you should never exercise again. You've had trouble exercising, exercising's off the table for you, you can never ever do it again. Would anybody even hear and take me seriously if I said that? But if I said, hey, look, your body is hurt right now. You have a stress fracture in your leg and you need to stop for right now until you are healthy and then go back to it. Could you guys get on board with that? That's the difference between helping someone get back to health and keeping someone ill. The other thing, dieting, body image dissatisfaction. Do you know anybody who doesn't have it? No, we've already agreed on that, right? So when somebody says, I don't like the way I look or I'm dieting, our first response is often, let me help you. So I always joke that I have a teenager at home, and I used to say when my kid comes home and says, Mom, I want to join a gym, and I want to work out and I want six-pack abs, because he totally said that. I said, great, I'll join the gym with you, let's do it. And he said, well, I didn't really want you to go with me, right? And when he said, I want to eat healthier, I want to, practice good habits, and I want to give up junk food. I was like, high five, you've discovered that we don't get to eat whatever we want whenever we wanted. But if my child then lost weight, I would be sitting there going, wait a minute, is this what I want? Maybe, maybe not. And if he then got diagnosed with an eating disorder, boy, would I feel guilty. Boy, would I feel responsible. because I was encouraging those very behaviors that now seem like they might have started an eating disorder. There's not really a situation on earth where I would want to teach my child how to engage in self-induced vomiting, but we know that this is something that teenagers talk about. We know that they share this information, and I know personally that when I was watching those videos about eating disorders, and mine had a ballerina who was throwing up in order to maintain her low weight. Some of you are nodding, I know, right? We all saw the same videos. I was like, that's a thing? You can do that? We've actually found that teaching people and trying to prevent eating disorders often initiates eating disorder behavior. And so the very things that we would want to protect our kids from, they actually put them at risk. So what is healthy and what is available to you? The first is, if you are worried that your adolescent is losing weight, unless they are coming from an extraordinarily high BMI, like the 99th percentile, we don't generally encourage kids to diet. What we encourage them to do is become more active, to stop gaining weight, to begin to move and maybe change the quality or the quantity of what they are eating, but actual dieting and cutting out food, we rarely, if ever, recommend, except for me, because I'm going to eat my hair tonight. If your child is experiencing cold hands, cold feet, and has lost more than about 10 pounds, please come see us. Right? Please come see us. Why? Because significant weight loss, 10 or more pounds, especially in a short amount of time, can be quite dangerous. And adolescents, because they've got that boost to grow, can sometimes maintain their weight and get taller, and that's also really dangerous. So if your child is growing and growing and growing and their weight's not catching up, sometimes it can be a little slower, especially when kids have a big, strong growth spurt. But if their eating isn't increasing, you should be concerned. If they're exercising more or engaging in physical activity that they weren't engaging in before, and after 4 to 6 weeks their eating isn't also increasing, you should probably be worried. If your child is eating food that you can't see, or they claim to not be hungry or come to the table, you should be worried about any of the eating disorders, no matter what size your child is. If you find food hidden in their room, or worse, you find vomit or syrup of ipecac especially being particularly dangerous, or laxatives, or have any suggestion that they may be using that in their room, those are also huge risk factors. One of the things that's also really important is most people that I work with think that eating disorders are a sign of something else. My daughter's really anxious, and that's why she doesn't eat, and that's what this eating disorder is about. Or, I know you want to help her change her eating, but you really need to address her depression. Or, my son has OCD, and this is just one more aspect of that. So can I tell you, eating disorders can co-occur with other things, but nothing trumps self-starvation in particular, or strong maladaptive behavior such as binging or purging. Nothing's more important than that, even if your child is depressed, because believe it or not, anxiety happens when our food is dysregulated. Come on, you guys kind of know that, right? That's why we have those Snickers commercials where you hand something to somebody, right, and they become a much better version of themselves. That regular intake is so important for driving actually emotion regulation and the capacity to engage in a healthy sort of way. So, the other truths about eating disorders is that they are treatable. And so I want to take a minute and talk about what kinds of treatments we have, because awesomely, we have several excellent treatments for eating disorders. And we have more all the time. For anorexia nervosa in children and adolescents, we do a strong family-based approach, really helping families disrupt the maintaining symptoms of an eating disorder, and helping families begin to shape their child's eating. We do the same thing with bulimia nervosa, although the targets are also not just normalizing meal, but disrupting some of those other behaviors that may go along with that. For ARFID, we do the same thing, but we actually help with food exposures, actually adding new foods into your diet that you might not otherwise be eating, which may mean doing things like practicing eating different types of ice cream or experimenting with your food or doing actual exposures where you cut up a tomato and you evaluate what it looks like and smells like. We can teach coping strategies, so there are many individual approaches as well, including cognitive behavioral therapy, which interestingly also is the gold standard for depression and anxiety. So when parents come in and they're like, I'm worried about this, we can say, we know these treatments help with this as well. Family-based treatment also helps with depression and anxiety in kids. There are group treatments such as DBT, dialectical behavior therapy, where families may engage in learning coping skills and tools and strategies. And those seem to be as useful as CBT, cognitive behavioral therapy, for bulimia and binge eating. We also have neuroscience-based approaches now as well, where we're actually targeting cognitive process and cognitive content. In other words, how you think rather than what you think. And so increasingly, the science is coming to help us understand better how we can actually change your brain functioning on a structural level or on a neurochemical level. And for binge eating and bulimia, there are actually medications that can help with treatment. Unfortunately, there are no medications that are effective for the treatment of anorexia nervosa. And generally, unless we're treating a comorbid or co-occurring condition, we don't recommend using medications. So those are some of the basic truths and myths that occur around eating disorder. I would really love for people to be able to engage a little bit around asking some questions and things like that, but we want to make sure that that's fairly private. So if we can shut off the tape.